Veteran Service Officer from Waukesha County. One of the things I realized was that there was a big disconnect between what we offer in the community and what our veterans knew about what we had in the community. We put together this Veterans Resource Fair where we brought in about over 50 agencies over 2 days, introduced themselves to the community, our veterans and their family members. The other thing that I did was I brought in some training on opioid overdose prevention, a chemical called Naloxone. So we had some training over the 2 days for veterans and their family members, because according to the VA, veterans are about 30% more likely to suffer from an opioid addiction. So we wanted to provide that resource here where they could get trained and also get the kits to take with them.
So the first thing you want to do when you come upon someone that is unresponsive and you're not sure what is going on is make sure that you take care of yourself and keep yourself safe. So the first thing you want to do is look around the scene and make sure the scene is safe. You know, is there traffic around? Is there a fire or anything like that? Secondly, if you come across someone who you suspect might be having an overdose, you want to look for things like needles or anything that could injure you. So if you do come across a needle like that, maybe in the arm or wherever, you need to very carefully pick that up and move it. So if this were an uncapped, well, here's one right here. If this were an uncapped needle and I were coming upon somebody, I would want to very carefully pick this needle up with your thumb and forefinger and move it to someplace that's safe and out of the way. You don't want to keep it on the floor because eventually you will be on the floor kneeling and you don't want to run the risk of a puncture. So in this case, I'm going to pick it up and put it on the back table. We'll take care of that later. Then what we want to do is make sure the person is alert or not. So you want to call them, shake their hand, their arms, pinch them, do that sternal rub. If they are not responding, then we need to progress to the next step. It shouldn't take but maybe 5 seconds to 10 seconds of checking them to see if they can respond. So what I want to do is, Annie, are you okay? Hey, can you hear me? Wake up, can you hear me? If there's nothing there, then I need to check to see if they're breathing, if they're exchanging air. If you can see, our mannequin here is a little, has blue tinged fingernails, purple and blue lips. It's very common when someone is having an opiate overdose or not breathing. In fair-skinned people, the color is kind of a purple blue. In someone with a darker skin pigment, it might be an ashen color. So we're looking, and then what we want to do is, okay, now there's something going on because I'm seeing blue fingernails, blue lips. Are they breathing? I might need to just open their airway, which is just simply a head tilt and a chin lift. I put my ear to their mouth and I look at their chest. I want to look, listen, and feel. I want to see if that chest is rising. I want to listen to hear if I have any air exchange. And I want to feel if there's any good air exchange on my cheek. So I'll take a moment, 5 seconds or so, and I'm not hearing or seeing anything. Here's where we yell for help. Even if we're alone, we're going to yell for help. We never know if someone's around the corner and can hear us, then come to help us. So here we just, help, someone come help me. This person isn't breathing. Then we want to administer 2 rescue breaths. And that's why in each of the kits we have one-way valve masks to help protect you. And so we would just simply read what's on there. It's very, very clear. The masks are a little bit different in each. In this case, there's one of those little mouthpieces. So we would be able to put it in the mouth and put it up, okay? This is a barrier mask. It protects us from anything such as blood or other body fluids. Because we talked about opiate overdoses maybe taking hours to happen, there could be things like food or whatever in there, so we need to be careful. They could have also maybe bit their tongue if they had fallen, and so there could be some blood, so we need to protect ourselves. Here's where then we would give our 2 rescue breaths. If the breaths go in easily, that's great. We don't have any problems, and we can continue on the process of what we're doing. If the breath is stuck and it's a fight, we will need to see what's going on, alrighty? So we'll need to pull this out, and we might have to give a look in their mouth And that's why we have the gloves, so that you could even do a finger sweep if there's a bubble gum or food or anything in there, so that we can get rid of that and then go back to giving the rescue breath. Hopefully at this time, someone is here to help you, in which case you can then say, you call 911 and go get my naloxone kit if you don't have it. In this case, we're kind of assuming you have it already because we have the mask and all that. So Kelsey, call 911, and then we can go on with the rest of the rescue as needed. So while what you're going to tell them is you have someone who's not breathing. So then we go ahead and complete our rescue breathing. As soon as the naloxone comes, whether you have it or if Kelsey went and brought it to you, as soon as the naloxone comes, you can administer it. And we offer in Waukesha County 2 different forms of naloxone for your rescue. We have the nasal form here, which we can talk about. This is a 4 milligram dose, but we also have the intramuscular form, which is 0.4 milligrams. It's really a personal preference. There are pros and cons to both. At this time, really whatever works for you. If you're comfortable with needles and you like this format of delivering the medication, great. If not, the nasal is just as fine. So in this case, it's pretty self-explanatory. 2 fingers on top and 1 in the middle. At this point, you want to tip your head back as far as you can because you need gravity to help you a little bit, and you need this medicine to get delivered into the sinus mucosa or the nasal mucosa. And you put it in as far as you can. I can't get it in her nose very well, but I go all the way up to my fingertips, and then I just push the button, in which case the medicine is delivered into the sinus cavity. There it will be absorbed through the bloodstream and then taken up and start working. In the meantime, while this is starting to work, you want to continue to do your rescue breathing if you need to. Rescue breathing should be done about 1 every 5 seconds. Sometimes what people have done in the past is 1 for me and 1 for the victim, and that's how they can do it. Naloxone should start to take effect in about 2 minutes. If 2 minutes have gone by and you're not seeing any change, it doesn't mean that it's not working. It may mean there's just not enough naloxone to offset what's on board, in this person's system. So then you will re-administer and repeat the dose. That's why every kit in the nasal has 2 administrations, and in the IM, we give you 5 doses. Okay. At that point, if they do start coming around, then we want to put them in what's called the rescue position. Rescue position is very easy to get into. I always think of it as a high 5, take the other hand and it becomes a pillow for the head, bend the knee up, and then you just turn the victim to their side. All right, let me show you here. So it's high 5, right? Pillow for the head, bend the knee up. You can grab their belt loop or their pants and their shoulder, and you just pull them right on over. And that's the rescue position. You want to continue to monitor the victim and make sure they're doing okay until the rescue help comes. So at this time, the EMT should be here. In the state of Wisconsin, all EMTs carry naloxone, and they're all trained how to use it. So by the time they come, if you've used both of your doses, they'll have more. Okay? Any questions? Yes.
How do you know it's a drug overdose and not just like a heart attack?
Okay, we've talked about that. And so if we look, the one thing you want to do, you'll see the blue lips, all right? You'll also see pinpoint pupils. When you look in their eyes, some people have a little handy-dandy flashlight. You can look in their eyes and they'll be pinpoint, tiny little pupils, all right? Other things that you'll see is some gurgling type breathing. We call that agonal respirations. It's not well enough, the respirations are not strong enough to sustain life, but they almost are like a gasp, is what it sounds like. You think they're breathing, but they're not.
I do have one question. With the nasal, do you have to close the other?
No, not for this type of nasal. For the other kind, we did.
Okay.
But for this one, you can just administer it, and then as long as their head is tipped back. So one of the pros for the nasal is it's very easy. There are no needles. It's pretty quick acting, and it's very strong. However, one of the cons is if you can't get your victim into the lying position like this, if we gave it this way, because they can't snort it up, it's just going to run out. So that's a big con. So we might administer it and not get what we wanted, which is one of the positives about the IM injection, is that when we give it, we know they're getting all of this. It's being directly injected into the body. Whereas with the nasal, some of it might not have gotten absorbed.
Good question.
And it doesn't matter which side of the nose you use. However, if you have to give the second dose, you might want to think about switching to the other side. Just thinking about that.
I've heard conflicting things about that.
Yeah,
I was trying to convince me that you
have to because it's like a loaded syringe. It's got enough. Great. Well, thank you two for coming and being willing to be trained on what an overdose looks like, how we can prevent an opiate overdose, and how to administer naloxone. I really appreciate your efforts to help save a life. We are able to do this today because the Department of Health Services in Wisconsin has given us a grant here in Waukesha County to help us bring this education out to the public. One of the really nice things about naloxone is that there really are not any side effects per se. So if I mistakenly give naloxone to someone who does not have an opiate on board, nothing will happen. Which makes it a bit different than, say, an IED machine or an EpiPen or even insulin for that matter, because some of those can have negative effects. So that's why we're able to do what we're doing. Okay. In opiate prevention, there are 5 key strategies that we need to learn, and we're doing that as part of this grant. We're doing like 3 of them, which is just great. So the first one is, and you guys are part of that, learning how to identify, prevent, and manage an opiate crisis, all right, an event or overdose. The next thing, if you take nothing out of this entire training, what I want you to do is remember to call 911. All right? Everyone's trained. If you feel comfortable doing more, fantastic. If all you feel comfortable doing is calling 911, perfect. Great, that's what we need from you, all right? And the other thing is, as you know, we'll train you on how to administer naloxone. And here we can have our choice of nasal naloxone or the intramuscular naloxone. There are a few other treatment things of the 5 tiers, but this is what we're doing. So as we know, opiates come from the poppy plant. I always thought that even though it was the poppy plant, I always thought it was the flower that got harvested. It's not. It's actually the sap of the poppy plant that gets harvested. I liken it to maple syrup. You know how we tap a maple tree and we boil the sap down and we make maple syrup. That's kind of what opium is, and through that process. Okay? Kind of cool. I'm sorry, I'm a little weird like that. What can I say? It works. All right. Sadly, it can be misused very easily. So as good as it is, it also comes with a lot of risk as well. There are many, many opiates. Opiates can be grown naturally, like we talked about the poppy plant, but they can also come synthetically. So we have many different variations, such as what? If I said opiate to you, what's the first thing that popped into your mind?
Narcotic prescription pain pills.
Okay, prescription pain pills. What do you think of when I say opiates? Same thing? Okay, well there's heroin, methadone, even tramadol, which is very well prescribed, especially for arthritis, used for dogs and cats for arthritis. Tramadol has an opiate in it also. Okay, replacements. And knee replacements, yep. So there's so many out there that we can't spend all this time naming all of them. But what we do need to know is that even though we have hundreds of different names of an opiate, they all act in pretty the same, similar fashion. So we have opiate receptors throughout our body, in our brains, along our spinal cord, and in our gut. And I almost like to think of the opiate receptor as like a little dish, all right? And it kind of sits there. And then this opiate comes and takes its place. So this opiate receptor controls our breathing, but it's also our pain sensation. So the pain comes and goes to this receptor, and what happens is when we take a pain pill, the opiate comes and sits here and blocks that pain sensation. So I no longer feel the pain. That's why it's working. But it also reduces everything and slows everything down. So when you think of opiates, always think of slowing down. It kind of slows your senses down, slows your breathing down, slows your heart rate down. Okay? All right, so it can cause constipation and whatnot. So here's a really good picture of it. See it there? There's that little receptor, and there's what the opiate looks like.
comes, it's almost like a magnet. That little, you know, how magnets attach to each other. That can be what it looks like. So when we take opiates, 3 things can happen. We can have what's called an intolerance. We can't take it. We have an allergy. You know, people get sick to their stomach or they get hives and get itchy. The other thing that can happen is a tolerance. So the more we take, the more we need. All right? Our body develops this sense of, well, you know, 1 milligram isn't doing it enough. I need 2 now, or I need 3. All right? That's called a tolerance, and it begins from the first dose. Usually kicks in becomes very evident in about 2 weeks. Remember I was telling you about mom, right? The other thing that can happen is both a physical and a psychological dependence on it. And that's wherein lies the problem. It's where the withdrawal symptoms will start taking effect and whatnot. The important thing to be remembered about an opiate is they can be taken in any way. Opiates can be swallowed as harmlessly as a pill. It's a prescription, it can't hurt us, right? It's a pill. But they can be injected, they can be sniffed or snorted, they can be smoked. But here's one that oftentimes people forget is they can also be absorbed in patches. So think of fentanyl patches that people use for long-term chronic pain or cancer pain. So it can also be absorbed through the skin as well. What we need to remember though is that opiate overdose doesn't always happen like it is in the movies. It's not always instantaneous. It can happen that way, but it can also take hours for it to happen. All right? It can take minutes to hours. So when we come across someone like we did earlier, there might be that they're choking as well because there might be gum or food or something in the mouth. All right? So it doesn't always happen like I take it and it's instantaneous. This is just another recap. Remember, we have these receptors. The opiate comes and sits on there. It blocks our breathing and it slows everything down. It slows everything down to the point where we're not getting enough oxygen to sustain life. And then we have death occur. So who's at risk for an opiate overdose? I'm going to quiz you guys. Who's at risk? Who do you think? Say it loud, because you got
Everyone.
Everyone, exactly. Really, absolutely everyone. I mean, everyone, even the family dog could be. I mean, think about what if the puppy gets into, your pills? So he or she could be at risk. What about toddler Timmy, who, the usual? What about grandma, who's been taking her opiates for a long period of time and the pain is so strong that she's going to take another dose? Mm-hmm. Okay, so I like to think of opiates as an equal opportunity employer. It knows no bounds, no race, no creed, no color, no sex, no income level. So who's at risk for an opiate overdose? We now know it's an equal opportunity employer, but we all know that sometimes there can be things that put us at a little bit higher risk. For instance, people who've been using for a long period of time can be at a higher risk for an overdose. We don't think of that often. Household members can be at risk for an overdose. People who have other conditions, chronic conditions, liver diseases or lung diseases, we don't clear that opiate out of our body like we could, so it can build up in our system. Switching between modes of administration. This is one that we don't think of. We talked about how they can be swallowed or injected or sniffed. But if I switch between those modes, that can put me at a greater risk for an overdose. Right? As well as the purity of what I'm taking. So going above our tolerance level is what I talked about. We have this main, let's call it the lethal level. We can only take this much before it tips the tea kettle. Well, if I'm developing a tolerance, I start down here, right? So there's lots of space between here. I got lots of room to play. But the longer I use it as I develop tolerance, you can see where this little window becomes tighter and tighter. And that puts me at a greater risk for an overdose then. Mm-hmm. Mixing with other drugs can put us at a risk for an overdose as well. And when I say other drugs, I also mean alcohol. So you then take something that's going to slow your system down, then add the opiate, and you can see how they kind of mix together. Benzodiazepines are also a problem. People take those for anxiety, Valium, and things like that to help us relax a little bit. Same thing. So now that you've been trained and you're going to do the best of your ability and what you feel comfortable with in a rescue, please know that if you are in good faith acting with what you've learned based on today, you cannot be sued for anything that may occur. Right? Don't quote me on that, but that's what my understanding of the Good Samaritan Act is, which is again why I really want to reinforce with you, only do what you are comfortable doing. Just because we're here does not mean you need to take naloxone if you're feeling uncomfortable with that. If all you can do is call 911 and that's where you feel comfortable, perfect, okay? But if you want to go through the whole rescue, we've given you enough things in the kit to keep you safe, all right? So what comes in the kit? The kit will come with a pair of nitrile gloves, non-latex gloves, all right? It will also come with a valve mask, a barrier valve mask, so you can deliver the rescue breaths. It also comes with a little pictorial step-by-step guide, because who knows how long it might be from this training till the time you might need it. And I'm a firm believer that a picture is worth 1,000 words. So if you need to, you just pull this out and follow the pictures. In each of the kits, if you would use your naloxone, there's something called a field report. We always know that our memory is best right at the time. And so what we ask you to do as part of this grant is that if you could check the boxes. For instance, we were in Waukesha County. I found this person in my home, right? And it was my friend. Just tick as many of the boxes as you can. And then when you need to come back to get your naloxone refilled, you can bring this with you. Then we have a little bit of information about what to do if you're pregnant. Is it safe or not? Well, we don't have any studies on human beings whether naloxone is safe or not. I say if you don't use the naloxone and mama dies, so does baby die. So we're kind of stuck between a rock and a hard place. But here's where that calling 911 is so important, because we do know that babies can be born addicted to opiates. So maybe we can take it to the next line and say, yeah, if the naloxone's working on mom, it's probably working on baby. Baby might be in distress, but I called 911 and they are coming with the support systems they need to help that baby live. All right. Is there an allergy to naloxone? There can be an allergy to naloxone, but again, if we don't give the naloxone, they're gonna die. And again, the EMTs are coming with the proper medications if there should be an allergy to do what needs to be done. Right? It's rare, but it can happen, but they're in no position to tell us they have. Because they're unresponsive, so we need to go ahead and get that. Naloxone likes to be kept at room temperature. So that means we can't, in this state, keep it in our glove box, because you know what it's like. Summertime, woo, 130, wintertime, -30. So it travels well, meaning we can take it on excursions, we can put it in our purse or in our pocket and carry it with us, but we can't keep it at those sustained temperatures for a long period of time. So I recommend people keep it in a place that's easily accessible in their home or on their person. It shouldn't be locked up, because at that time when you're in that crisis state, you don't want to have to be dealing with what's the code for that or where's the key or anything like that. So some good places to think about keeping it might be the top shelf in the kitchen, maybe your underwear drawer, in the front and where no one else goes, that kind of thing. It should be fairly accessible. Any questions about naloxone or what to look for? Or hopefully I didn't miss anything.
So as far as if we would load this up, so this is just what it's going to look like with the cap on. So you're just going to take this orange cap off here. And then all it's going to be is it's just going to be through a rubber stopper that you're going to be pushing the syringe through. One thing, just make sure this is a removable tip needle. So when you take it out of the package, just kind of give it a twist and you can kind of hear it and feel it click. Just make sure that it's on tight so that when you're doing this, it doesn't pop off. So I found that the easiest way to do this, and as far as with loading this up, whatever you're comfortable with is 100% fine. I have found that the most people find this the easiest way to do it. So first we can take off this top here. What we want to do is we want to pull the syringe back a little bit. Now, usually when I'm doing this, I kind of show you up here so that you can, that you can see it up here. Now, if you're in a panicky situation, it might be something where you're kind of shaky. As far as even pushing this through the stopper here, putting it down on the table, just so you have a little bit more leverage to get it through, might be a good idea. So all we're gonna do is we're going to push this through this stopper here. Now, if we take a look at how I have this currently,
You can see the needle in there?
yep.
And
So I have the needle all the way up to the top and it's just in air. So if I tried to get the liquid in here, it's not gonna do anything because it's just in the air right now. So what I wanna do is I just wanna make sure that I have this needle point at the bottom as much as possible. Now, why we drew this back is what I can do is I can push all of this air into here. And now I'm gonna again make sure that I have the tip of my needle at the bottom as much as possible. All I have to do is I just have to release my thumb on the bottom. I don't actually have to draw it up. Because by pushing that air in, it creates a vacuum.
Okay.
And now all I have to do is kind of,
it might keep going.
yeah, that's okay, is just focus on having that, that needle point at the bottom as much as possible. Now I can take it off. It might splash out a little bit, but that's okay. So now I have pretty much all of the contents in the syringe. Now all I would do is just push that air out until you have it pretty much at the top. You can push it until you see a little come out if you would like. You don't have to. You would have to pretty much inject this whole thing of air into an individual to actually have it do any damage. So then this would be ready to go.
How much is a dose?
So it's going to be about 1 cc, but it's going to be this entire vial. So one of these per one syringe. Yep. So this is going to be 1 dose. A little more, a little less. You know, if you have a drop or 2 left in here, that's okay, as much as you can get into the syringe. Now, as far as actual injection, this is going to go in one of 3 spots in the actual body. So it can go in the upper arm, it can go on the front thigh here, or it can go on the back side. Yep. In the butt.
Okay.
Yep.
Okay.
I think we kind of give you those options just because depending on the position that an individual is in, it's kind of whatever you have best access to. I will say, especially if you have someone who's very frail, sometimes a young female, sometimes this can still be a very small part on an individual. I would just suggest possibly going into a different area, possibly the leg here. Usually the leg,
target there.
Yep. Usually the leg is going to be, you know, an area that's going to be exposed on an individual as well. This is a pretty thick intramuscular syringe, so this is going to go right through clothing. So right through jeans, sweatpants, you know, a jacket, if someone's wearing a jacket as well, you don't have to worry about taking off anyone's clothes at all. Especially if the intramuscular is the form that you're going to have, especially if it's something that you're not familiar with necessarily with giving injections, anything. Sometimes, you know, especially with going through the clothes, then looking at skin when you're doing it, sometimes that's a lot easier for individuals as well. So going, you know, right through a clothed area versus if I was wearing short sleeves and, you know, I might be seeing it going through skin. So then all we would do, so we're going to say that this is going to be a muscle. And actually, if you wanted to do this, you can. If you wanted to actually inject this into here. So this is going to feel very similar as to when you would be injecting this into someone's muscle. So the skin is kind of going to feel similar to the skin, and then the internal part as well. So all you're going to do is you're going to insert the syringe all the way into the orange.
Because it's an intramuscular, you want to go in at a 90 degree. You're not going to go in on an angle, so almost
Straight
like a
in.
dart. Yep.
Yep.
Well, that's not hard. Just poke it in.
Yep.
Yep.
All the way in, and then slowly push down. Yep. You can kind of feel just a little bit of resistance, but you want to put all the liquid in.
And now pull it out.
Yep.
There you go.
Piece of cake.
Yep. Absolutely. And then you would just want to remember to try and cap the syringe again, just because we don't want to throw this on the ground and forget where this is, and then someone come across it later.
Okay.
The nice thing when an EMT when they come, they'll do what they call like a biohazard sweep. So this is the time when we can give them our spent needles, or if we found one. One thing I forgot to tell you is when they do arrive, you want to give them a little bit what we call a warm handoff. Just tell them what happened. I found this person, they weren't breathing, here's what I did. I gave them a dose of Narcan, that's where I'm at. And then they can take over from there. Or I had to give them 2 doses of Narcan and I'm still giving them rescue breaths. And then they can take over from there.